Meeting is called to order. Would everyone rise, please, and the Pledge of Allegiance?
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, would you take the roll call, please?
Director Danielson,
Present.
Director Nixon,
Present.
Director Stewart,
Present.
Directors Wallace and Director Evan.
Thank you, thank you. We have an educational session. Are you
I'd
going
like
to do
to
the
introduce the speaker. So our education, we have actually two education sessions tonight. The first one is on heart health by Dr. John Cecil Walks. Dr. Walks was born in Sydney, Nova Scotia, and decided to follow his father's footsteps by pursuing a career in medicine. He is a graduate of Stanford University, where he graduated with honors in humanities, and then went on to study medicine at UCLA. After graduating from UCLA with honors, he accepted a general surgery residency position at Baylor College of Medicine in Houston, Texas. And from there, he moved into a thoracic and cardiovascular residency at Baylor. He trained with Dr. Michael DeBakey and joined the DeBakey Heart Team at Methodist Hospital in Houston, Texas. And just before he came to Washington Hospital, he was associate professor at the University of Texas Health Sciences Center and serves as the director of the valve program at the Memorial Hermann Heart and Vascular Institute at the Texas Medical Center in Houston. In the past 5 years, Dr. Walks has published extensively in the area of cardiac tumor surgery, valve surgery, thoracic trauma, and minimally invasive heart valve surgery. Dr. Walks' primary focus is adult cardiac and thoracic surgery. So without further ado, Dr. Walks.
Thank you.
Well, I'd like to take the opportunity to thank the Board of Washington Hospital for having me here tonight. And as many of you know, February is the American Heart Association Heart Health Month, or the Heart Healthy Month. So we thought we'd talk a little bit about heart healthy living and ways that we hope to bring heart healthy living to the constituents of our hospital and the community. So just as a brief overview, we're going to talk a little bit about health in general, heart health, a little about heart disease, ideal heart health, and as I'll talk a little bit about as we go along, in the last 12 to 13 months or so, there's actually been a definition put forth by the American Heart Association about what a heart healthy lifestyle is. So what they've done is they've looked at people who they consider poor health with respect to their heart, intermediate, and excellent health. And as many of you may be familiar with, the American Heart Association has had a goal to reduce the incidence of death from stroke and myocardial infarction by the year 2010 by 30%, and they actually reached many of their endpoints. So now for the new project that we're working on through the AHA is through the year 2020, and it's to improve people's heart health by 20%. Now they've kind of widened the definition of heart health to include these three categories, and what we'd like to do is see people move in between in between the different grades. So for example, if you have poor health, move into intermediate. If you're intermediate, move into the excellent level. So we'll talk a little bit about that. I want to talk a little bit about some of the controllable factors that we have as human beings and with respect to our heart health, and then some of the non-controllable factors, and then end a little bit with signs and symptoms and what you should really look for with respect to heart disease. So as I was alluding to, this came out in circulation in January of 2010, and what the AHA has done has set a goal for 2020 to reduce the incidence of heart disease by 20%. And they've really broken it down into both adults and children. So you'll see for the first time, they've kind of defined what it means to have a healthy lifestyle. So they've broken it down into what we call the simple sevens, so an easy way for us to remember that. So we think of smoking, our body mass index, our physical activity, our diet score, our total cholesterol, blood pressure, and our fasting blood glucose. So these are the areas that you'll see. And just as an example, you can see that someone who is a smoker and has a BMI or body mass index of 30 or greater and meets some of these other criteria falls in the poor health range. And to fall in that range really pretends that within your lifetime you have a significant risk of developing heart disease and developing a complication from that, which could include a myocardial infarction. So we're really going to focus on that at the AHA to improve that. Again, there's poor, intermediate, and ideal. We recognize that not everyone is at their ideal definitions as illustrated by the simple sevens, but we want to try to move people in between these different ranges, and by doing so get a 20% overall improvement. So what constitutes a good healthy heart-related lifestyle? So and what are the things that impact your health with respect to your heart? Well, clearly work does. I think if you're someone who works too much and has associated stress, lack of sleep, your children and relationships can influence things. Fitness, which is part of the Simple 7, as is nutrition and health. So all these things work together to impact your ability to have a heart-healthy lifestyle. Now, when you think about our community, we have a very culturally diverse community mix here at Washington Hospital in our constituents, and you'll see that the breakdowns here. But what's important to remember is that heart disease and death from heart disease still is the number one cause of death in men and women in our country. So although you'll see that, for example, with women and heart disease, there are unique aspects to that. We oftentimes forget that although there's a huge focus, and rightly so, on reducing breast cancer, for example, in women, heart disease still remains their number one risk. So it's important that heart disease not get lost in the shuffle. So again, you can see that there's about 398,000 people for men and 432,000 people for women who die from heart disease yearly, and for women, cancer, within which breast cancer lies, is a distant second, although, again, clearly very important. So what about women and heart disease? Because I think it's a topic that has become more increasingly focused upon by the American Heart Association. And the reason is that traditionally women have not had their symptoms appreciated as much as they should have been. So it's very common for women to develop heart disease and heart disease-related symptoms later than men. They're not usually identified as the classic disease symptoms, and it hasn't been until recently, when the focus has been put on that we've seen more people recognize those things. So for women, I'll oftentimes meet women who have had heart attacks or coronary disease symptoms who have unusual fatigue, sleep disturbances, shortness of breath, anxiety, or indigestion. And sometimes they get referred to other physicians and think that there's some other component going on, when in fact this is a sign of coronary artery disease. So what do we mean by cardiovascular disease? Well, cardiovascular disease, when I'm talking about cardiovascular disease, I typically mean coronary artery disease, and we'll talk a little bit about that. It means blockages in the heart arteries. And what I tell patients is, your heart's like any other muscle in your body, with the exception that it's specialized to pump blood to the rest of your body. So when your heart doesn't get an adequate amount of blood flow through the coronary arteries, the symptoms that you have are chest pain, shortness of breath, these symptoms I've talked about earlier. And about 1 in 4 people, their first symptom is that they drop dead. So it's important that we know what the symptoms are so that we don't become one of the 1 in 4 people. So heart disease also encompasses abnormal heart rates and rhythms or arrhythmias, heart failure, congenital heart disease, which we don't treat as much of. It's really focused on kids, or disease and heart disease in kids. Cardiomyopathy, which you may hear that word in the news, basically means some problem with the heart muscle, an innate problem. pericardial disease, or disease of the sac that your heart sits in within your chest, aortic disease, and vascular disease. And 9 out of 10 people with heart disease have at least one risk factor. And people will always say, well, what can I do to decrease my risk of having a heart attack? And I'll say, well, there are things you can't control. I mean, you can't control who your mother or your father are or were. So the genetic component of coronary artery disease or heart problems is something that you have little control over. However, your cholesterol, your blood pressure, diabetes, cigarette smoking, obesity, physical activity, and alcohol use are things that we can, in fact, modify. So there are some things we can't modify, and there are other things that we can modify. So it's important that we focus on the things we can modify. So going back to the American Heart Association, again, the goal for the AHA for the next 20 years is to reduce the incidence of cardiovascular deaths and stroke by 20%, as well as to improve people's disease. So to move you from either poor to intermediate or intermediate to excellent, or hopefully from poor to excellent. So this is really something that at the American Heart Association they're going to focus on over the next 10 years. And one of the things that becomes very important is what is your total cholesterol, maintaining an adequate normalized blood pressure. If you're diabetic, trying to get you into the non-diabetic range, and then modifying the things that we talked about. So if you're a smoker, we want you to quit, and we'll focus on smoking cessation, get you down to your healthier ideal body weight, and really do some physical activity. So I'll always preach, if you can do some physical activity is better than none. So if you're someone who has a hard time kind of getting motivated to do that, take the first steps rather than driving all the way into work. Maybe park a little bit further from your job and walk some distance, because any physical activity that you can do is better than none. So with respect to nutrition, our best weapons really are modifying some of the things that we eat with respect to cooking heart-healthy meals. You'll notice now, if you dine out, at many of the restaurants that you'll frequent, there's actually a breakdown of the caloric intake, what's in the food, and it really is a good idea to start kind of sensitizing yourself to that, because those are the little things that you can do to improve your health in general. And then heart smart shopping. So, I think that now if you go to the grocery store, you'll see that on many of the food products that you buy, there are labels that kind of break down what's in each product. And I think it's a good idea to get used to doing that. Stress management, I think we all would like to have less stress. And in terms of stress management, I think there are many tools out there to help with that. I think one of the easy things to do, and that I alluded to earlier, is exercising. And I think that exercise has been shown to modulate your stress level or decrease your stress level. So it's a good tool to both improve your heart healthy lifestyle in and of itself, and can relieve some of your stress. Physical activity, again, as obesity rises, so does the level on our impact of our nation's health. As all of you, or many of you may know, the current First Lady of the United States, her primary focus is on childhood obesity. And clearly that's something that we have to get a handle on, because as our children become more inactive, there's no doubt that the incidence of coronary artery disease and heart disease and some of these other problems with diabetes, et cetera, are going to plague our children. So it's important that we not only become active ourselves, but encourage our children to do the same. Weight management, again, some activity is better than none. With respect to our body mass index, or our body surface area, we want to try to get that down below 20 if possible. And again, to learn more about some of these techniques, you can log on to the AHA website. Smoking. Smoking is basically, I know it's kind of taboo here in California, but in Texas, where I recently came from, it's more embraced. Let's put it that way. But clearly, smoking is something that has very very few positive benefits in the long term. It increases your risk of throat cancer, increases your risk of blood clots, peripheral vascular disease, and no doubt has an effect if you're someone who needs a stent, which is what your cardiologist may put in for coronary disease, or God forbid, heart bypass surgery, which is what I do. It can actually hasten the recurrence of the disease if you don't quit. So just to leave you with the signs and symptoms and what we mean at a cellular level, or at kind of the basic level, what's going on in your heart. This is really a depiction of your coronary arteries. And again, as I said, your heart's a specialized muscle that pumps blood to the rest of your body. And these are the coronary arteries here on the surface of the heart. Now, if you interrupt blood flow, or if you starve your heart muscle for blood flow, you get an infarct or scar, dying muscle down here. And that's what this may look like. And you'll see that it's composed of cholesterol, a blood clot, and these two things interact within the artery to limit the amount of blood flow to that muscle or that tissue. And what does that mean to us? I mean, what do we experience? Well, we'll experience sweating, shortness of breath, chest pressure or pain, and oftentimes patients will say that it feels like an elephant standing on my chest. And sometimes this will radiate up to your jaw or down your arm. And you may, in fact, have some nausea or vomiting associated with it. And again, just to reiterate, in ladies, fatigue, indigestion, anxiety, those are some of the more atypical ways that they'll present with this same process. I'd be happy to answer any questions.
Questions?
No, I thought it was a great talk, great for the month of February. Let's everybody get heart healthy and
Okay, thank you.
do the right things.
Thank you, Doctor. Chris, would you introduce? Or Kimberly, I'm sorry.
So our second presentation is on patient privacy, ethics, and the laws by Chris Lavoie. Chris Lavoie obtained her BS in nursing in 1972 from San Jose State and began her career as an ER nurse. In 1992, she obtained her master's degree in health sciences administration from St. Mary's. Chris began her career at Washington Hospital 30 years ago and has held various positions within the hospital, including nursing supervisor, quality assurance coordinator, chief of professional resources, as well as her current position as chief of compliance. Chris happens to have many artistic interests, including photography and quilting, and she is a drummer in a local community band. Chris?
Thank you. Good evening. Thank you for allowing me to spend some time tonight talking about privacy. And I'm going to tonight approach this from two different perspectives, the ethical perspective and the law. As it relates to ethics, we have an ethical obligation to protect the information that our patients provide to us. Patients allow us into some of the most private and personal aspects of their lives. They tell us about their past. They tell us about what is wrong with them. They tell us about symptoms that they may have. Historically, there has been almost a sacred relationship between patients and their physician. Probably second only to the relationship that an individual may have with their minister or priest. Just this morning, as I was getting ready, I heard a discussion on a radio news show related to the amount of mental health diagnosing that is done by patients' primary care physicians. And that obviously is based on the fact that that's the person that the patient feels comfortable talking to, and that's the person that's first going to recognize that there's a problem. Our role as the hospital and as healthcare providers is to honor that trust so that when that patient tells their doctor and their doctor records it in their chart, it becomes our responsibility to safeguard that implication. Think of the implications if we, in this industry, run the risk of losing that trust. If patients routinely withheld information from their physicians and from their care providers because they were afraid of what was going to happen to it. Diagnosing would likely become a guessing game. I think as we talk about the issues of privacy, that it's important that we also understand some of the other things that are out there that are influencing this subject. There are websites out there that pool information from a variety of sources and have a profile on you, me, that get information from where you shop, what you order online, what your interests might be. It's amazing when you see what's out there. So it's not a wonder that patients are nervous about their information. There is the increasing problem in our society of identity theft that patients, needless to say, are afraid of. And there's also the issue of the risk of information getting to employers and insurance companies. And patients, particularly patients with any sort of communicable disease issue or mental health issue, are very afraid of that happening. And so as we move from the ethics into the law, I ask the question, do we have privacy laws because as an industry we have failed to meet our ethical obligation to patients? I'm afraid that's probably true. When we talk about the application of privacy standards, and when I say standards, I mean both the ethical perspective and the law, we're talking about care and treatment, which is probably the bulk of the issues that come up as it relates to patient privacy. But we also need to think about marketing. It's no longer acceptable to market your services to specific groups of patients based on what their diagnosis might have been when they were here. There is a whole set of regulations and opinions on patient privacy related to fundraising, and indeed the hospital has a set of policies and procedures on that. In terms of education and training, very important that case studies are done, very important that we learn from actual care and actual circumstances. But there are situations where that is appropriate and there are situations where it is not. The hospital does have policies about de-identifying any information that's going to be used in education and training. And again, there is a whole body of law and a whole set of regulations related to the issue of patient privacy in the arena of research. Particularly interesting in that is the whole issue of the archiving of information and even specimens that may be used at some later time. So now I'm going to do just an overview of the laws related to privacy. And the first one, and it actually is the first one that we dealt with in California, and that's the California Medical Information Act, and that actually goes back to the early 70s. I'm not going to spend a lot of time on that one because it has sort of been overshadowed, if you will, by the federal laws and the latest additions to the California law. But the next one is HIPAA, and that actually is the Health Insurance Portability and Accountability Act. And HIPAA to many states was very new and very different. Like I said, in California, we already had a privacy law. You even now hear people talk about HIPAA when what they really mean is privacy laws in general. But HIPAA is sort of so dominant that it has become how we talk about privacy. Then we now have high-tech. And I have to read this because I never can say it without looking at it. Health Information Technology for Economic and Clinical Health Act. Indeed, part of the Healthcare Reform Act, and looking toward the issue of the electronic medical record. And For us in California, probably most significant, the two California laws, SB 541 and AB 211. So starting at HIPAA, starting with the federal laws, HIPAA was the first one to define what we now call PHI, or protected health information. And this is important because HIPAA defined it, and pretty much all of the other laws are consistent with this definition. So the information that is protected is past, present, and future health care and treatment, past, present, and future payment information, and anything that identifies the individual or could be used to identify the individual. HIPAA is the regulation that established the minimum necessary rule. And I think that one is particularly important. And what it means is that even when it is okay to share information, it is only okay to share the minimum necessary. So if the question is, did the patient have an appendectomy when they had another surgery a period of time ago, then that's the only information that should be sent to the next provider, the person asking the question, rather than saying, oh gee, here's the whole record. HIPAA also established a set of patients' rights. And again, this was not as significant to us in California because much of this existed with the California law. But in other states, this was significant, and it meant significant changes in the way hospitals and healthcare facilities functioned. So some of those rights, patients have a right to be informed of privacy practices. I know you all are familiar with the fact that you go to your doctor's office and they give you a copy of their notice of privacy practices. Patients have a right to access their medical records and their information. Patients have a right to amend their record to have something that they might write included in their medical record. And patients have a right to know who has received their information. So who has their information been released to? HIPAA also established the principle, and probably the most important piece of it, is the principle of sharing information, patient information, only as it is currently necessary to care for the patient. And that, indeed, that concept has been carried out through the other laws as well. HIPAA also defined the situations in which information can be shared, and some of those are treatment, payment, the hospital can submit a bill to an insurance company, and what is called healthcare operations. And what typically falls into that category are activities such as quality and peer review. High-tech is known as the amendment to the federal law. It imposes additional fines on hospitals and healthcare organizations for breaches. It requires the reporting of breaches, which HIPAA really did not. It imposes much more stringent requirements on business associates. And business associates was a concept that came out of HIPAA. And a business associate is someone who does something on your behalf. So if the hospital or a physician's office uses, for example, a billing office, a billing unit, and contracts for that service, the people in that billing unit are indeed business associates. And what high-tech did is say that those people have the same duty to protect information as the entity does. So that was a significant change and a significant burden placed on business associates. And then, as I said, high-tech is really related to our move to an electronic medical record, and it does require certain security and privacy provisions be considered as you are looking at introducing an electronic medical record. So now to the California laws, and these laws became effective in January of 2009. And back to my question about our ethical obligation and did breaching that lead to the laws. These California laws were indeed passed partially because of a situation at UCLA where there were people that were snooping into the records of celebrities, and you probably have heard that indeed one of those celebrities was Maria Shriver, and so we don't need to wonder what happened when the bill was put on the governor's desk. These laws prevent unauthorized access, to PHI, and that's very significant. The other laws, both the original California and HIPAA, talked about unauthorized use and disclosure. These laws now mean that it is a breach simply to go in and look. Even if you don't do anything with the information, even if you don't pass it on to anyone else, even if you don't sell it to the tabloids. And we will talk about this with each law, but these two carry significant penalties. So Senate Bill 541 applies to hospitals and other licensed health facilities. It requires organizations to put in place safeguards to prevent unauthorized access. So things like making sure that computer screens aren't visible to people, require such things as passwords, policies and procedures, staff education. Those are all considered safeguards. This law also requires the reporting of breaches to the Department of Public Health and to the patient. And the penalties, you see, are significant. They can be up from $25,000 to $250,000 per patient. Assembly Bill 211 and an accompaniment bill to 541 applies to individual health care providers. So it includes, it applies to me as a nurse, physicians in the room. It authorizes penalties to individuals, and it also allows civil liability for those individuals. It allows referral of breaches to the individual's licensing board. And as a nurse, that's pretty scary to think of something I might do getting reported to my licensing board. The other thing that AB 211 did was to create the State Office of Health Information Integrity, or you see it or hear it referred to as OHI. And that's an interesting organization. It has no budget, which means it is funded solely, and its existence depends on the fines that it is able to collect. So what are the behaviors? And I could have gone on a while on this, but I tried to pick out some of the things that I thought were sort of general in nature and significant in nature in terms of what is really prohibited by these laws. And certainly the concept of searching the computer, looking for information on friends, neighbors, someone you might know. Looking at the health information of a patient without a current business need to know. And that, again, goes back to that original concept that came from HIPAA. Singling out and contacting patients for purposes such as marketing. Discussing a patient in a public area like the cafeteria. And discarding patient information in an open trash area that is accessible to other people. So what are we doing at Washington Hospital as it relates to this? We have an organizational commitment to both the ethics and the law regarding privacy. It is consistent with our patient first ethic, which means that we make decisions and judge things based on what is best for the patient. It is embodied in our code of professional conduct. We indeed do have policies and procedures and physical safeguards in place to protect patient information. We have mandatory education of our staff related to this. We have a series of audit processes. We recently implemented a concept called fair warning that allows us to produce a variety of reports to monitor who indeed is accessing our computer systems. And we are committed to consequences for noncompliance. So in summary, Washington Hospital is committed to meeting our patients' expectations that their information is appropriately protected. Questions?
Thank you, Chris. Do you have questions?
Yes, Doug?
Chris, one particular point I'm not sure that I heard you say very clearly was that not only is the provider, the hospital, responsible for these fines if there is a breach, but the individual causing the breach can also be fined
Absolutely,
and taken to court.
absolutely.
So there's I want to say
So-
double jeopardy there.
Indeed, indeed, there is. The expectation is that protecting patients' information is a responsibility of the organization, but is also a responsibility of every individual in that organization.
Thank you. It was well done.
Here's the question. Consider I'm not a physician, a layperson. I'm a patient. The question is, who owns my medical records? Do I own it, or does the hospital own it? And related to that question, can I discuss my own medical history in public, in a place not quite like this, in a cafeteria, even though it's my own record? Can I do that? Am I breaking the law?
Let me answer the first one. The record belongs to the hospital. You have a right to access that record. You have a right to get copies of the record, and you have a right to include information in that record if you choose. So if you feel that there is something, if you get a copy of your record, feel that there is something that isn't in your record and you want it to be, or feel that there is something that perhaps is you don't agree with in the record, you have a right to submit information to be included in that record. And as it relates to can you communicate your health information to people? Yes, of course.
Even though it's in public to lay people?
That's
Well, we had that instance several months ago when my surgeon was taking me to surgery, and we were in the lounge and we were looking at my x-rays and my scan, and there was a little feeling of unrest because it was in the lounge. I had no problems with it. But some of the nurses felt that I could be violating HIPAA discussing my own findings with my surgeon in a lounge. I guess you've answered the question.
And I think if I were staff, I might have been uncomfortable with it too, but you do have a right to discuss your information wherever
you.
you choose to.
Thank you.
Hi, I got a question about your security. Do you guys have screen locks? So if the employee walks away from their login because they got to run into a patient room, that screen times out in a certain amount of time? That way no other employee or anybody else, patient, anybody walking in the hospital can go in there? Question number 2, do you have limited access to my records just for the nurse or the doctor that's taking care of me? Or can any nurse or anybody get in there and look at my records? What security provisions are you have in place so that doesn't happen?
In response to your first question, we do have our computer systems do timeout.
What's the timeout window?
I can't, for
I mean, if
every
it's-
system, answer
yeah.
that off the top
I mean,
of my
if it's
head.
15 minutes and somebody walks away, anybody can walk up and get into that computer, and you don't have any idea who's in that computer. If it's timed out after no keystroke after 5 minutes, 3 minutes, 2 minutes, tighter the window, the tighter the security, then you know who's on that system. Somebody else has to log in. So question number 2 would be, who can see my records? Anybody that logs into the system? Or shouldn't it be tailored to or tightened to the person that's taking care of me, my doctor, and my nurse? That way nobody else can look at my records.
I think I hear what you're saying. I think that in many circumstances, I think that is impractical. There are other people in the organization that may not be the physician of record that need access to your record in order to care for you. For example, the pathologist that's going to be looking at a pathology specimen. So there are other people in the organization that need access to be able to contribute to your care.
Yeah, so a little background. I work in technologies. I'm the director of a technology company, and we do support. I dial into companies like Fidelity. We remote into companies like TV stations. I have to have secure satellite key access for each of my employees that get into these systems. And they time out if we don't touch those keyboards. That way, if somebody goes in and grabs your 401k information, I know who did it. And it's not sitting there logged in for 30 minutes for the next guy to come up and look at that information. As you can imagine, patient information is just as important as your financial records. So if you're not timing these things out within 3 minutes at least of somebody walking away from that keyboard because they got to run into a room, they have access to my information.
No, we certainly can. We certainly will look at that.
All right, thank you.
Thank you.
Thank you, Chris. We now have consideration of the minutes of January 12, 17, 24, 26, 2011.
Madam President, I move for approval of above minutes.
Thank you. All in favor?
Aye.
Motion passes. Thank you. Our next agenda item is oral communications. Catherine, do we have any? Thank you. The board always appreciates hearing communications from members in the audience. And I will ask for consideration of the members who are present and a common courtesy that we are going to limit, as we have in the past, 3 minutes per presenter. We have a heavy agenda this evening, as usual. So again, I'd like to repeat, that's 3 minutes per presenter. And Catherine will be the keeper of the time. Okay, thank you. I'm just going to read out the names in the order that she gave me the cards. The first person here is Diane Stray.
Hello. I was here at the end of August talking about a situation on the birthing center that I had asked you as the board if you could look into what's going on in our unit. And it in fact has gotten worse. I wanted to make you aware of the problems with retaliation, personal integrity, and defamation of character continue. As you can see by the response here, there are many nurses here, not just from our floor, but from throughout the hospital, that are dealing with these same types of retaliation and working in a hostile work environment. Washington Hospital has recently stated that I am a disgruntled employee upset with a management decision, and as a result went off work claiming a workers' comp case. That is far from the truth. I was threatened by management that if I came back, they would be watching and waiting for me to slip up by, quote, watching my every move and documenting everything I do. I have a perfectly clean file. There's nothing in my file. In the beginning, the accusations from senior management was that nurses and doctors were stating that I was unsafe, along with several other nurses. They have since yet to prove any of that. There is no such documentation. They took me out of practice, put me in a remedial program, made me wear uniforms with 3 other nurses and walk into this building here every day for 9 to 10 weeks. There has been no resolution from this. In fact, just Saturday, I got a thing in the mail that my health insurance is done as of February 28th. I have done nothing but give my life and heart to this community. As a matter of fact, my father was the first defibrillator recipient here at Washington Hospital. Dr. Ed Whalen and Dr. Singali were the doctors that took care of him. He was the very first person that the heart defibrillator was used on, and it saved his life. My mother had her children here. I had my children here. I went to school later in life to become a nurse because I've always wanted to work in labor and delivery, and I got my dream, and it's turned into a nightmare. The situation is affecting other nurses. They're afraid of retaliation, and many of them are here but are afraid to speak because they can see what's happened to myself and Chris Silcox here. Washington Hospital is responsible for damaging my professional career, but they can't take away all the good that I've done and the loving care I've given to my patients. It's Washington Hospital's responsibility to make me whole. My health and the personal well-being of my family is directly influenced as a result of what's taken here. I implore you once again as the board, and Nancy Farber's not here, but I also implore Nancy Farber to make this hospital a place where people love to work and are not afraid of doing their jobs. Magnet status is something the hospital's striving for. Let's get on track of what really this means to its employees and the patients that come through these doors. I'm asking for your help. We've tried, every way we can. We have the union here representing us. We have all the other nurses. I'm asking you, as the board, to please look into this matter. It is very serious, and I would like my job to be safely done without worried about someone writing me up every time I turn around when I have had no write-ups to this day.
Thank you.
Thank you. And I also wanted to ask, last time I was here, I made sure that everyone got copies, or I spoke with Catherine Bartlett, and she had told me they've gotten. Did you ever receive any of your copies of all of the information? I was at the last meeting. It was a 3-page document, and she promised me that it would be sent out. In fact, she told me that she had sent it out. So I'm not sure if any of you got it. I would like to resend it again because I have a feeling you didn't. Did any of you get it?
Frankly, I don't remember.
Okay. Okay. Well, thank you.
Thank you. Our next speaker is Christine Silcox.
Good evening, and thank you for being here for me. I'd like to start out by saying that I have been a long-standing,
Christine,
valued employee.
If you'd stand.
Sorry, I'm a little short. I've been a long-standing, valued employee for Washington Hospital for 30 years. 18 years as the crisis nurse in the Washington Hospital emergency room and mental health. I then transferred to 12 years in labor and delivery, and I consider myself an excellent nurse. The best thing I do is work as a patient advocate for my patients and their family. I was the hand-picked labor and delivery nurse for the Sentinel event mom that lost her stillborn baby. The retaliation that the hospital has put on me since that is incredibly intolerable. It's gotten much worse. It's time for the community to know what is going on in this hospital to its nurses and how they can be better taken care of here in this community. Administration and management have created a hostile work environment. They have slandered me and my reputation. They have taken me out of my professional practice for 8 months with absolutely no just cause. I was called into the administrative offices and I was told that many nurses and doctors have various complaints against me. None of that is founded at all. I have a perfect file. I have an excellent reputation in this hospital. The doctors have come forth to administration and have asked for me please to come back to work, that I and other nurses are extremely valuable on the unit, and they don't want to do without us. They were told to stay out of it by management. A committee was formed so they could voice their complaints. Nothing positive has come out of that either. I am now out on a medical stress disability leave because I am not going to be taking care of patients in an unsafe environment. I believe the nurses here need to be empowered and respected. And until this happens and there's huge changes in management and their tactics and how they deal with nurses, this is not going to happen. Washington Hospital is directly responsible for the lies and the slanders that I have subsequently gone through. The hospital refuses to meet with us about these issues. The hospital needs to make us whole on every extent of our CNA contract. The hospital spent hundreds and thousands of dollars training us through the Marie O'Rourke Hospital of Excellence towards their their magnet status. Pardon?
I'm sorry, Christine, your 3 minutes are up.
Okay. I'd like to end up by saying that the nurses behind me are my peers, but they are my sisters and they are my family. And we are all feeling the same about this situation. And it's very much beyond the time the community needs to be aware of what's going on. Thank you.
Thank you. I apologize in advance if I mispronounced the last name.
It's Lisa Bates.
Lisa Bates. Thank you.
Hi, my name is Lisa Bates. I've been a nurse here for 12 years. I just wanted to give 2 quick examples of what these nurses are talking about. There's about 25 nurses behind me, 2 other unions here with some of their employees that are going through similar things that we're talking about. I just want to read from your code of conduct. It's memorandum number 0-5A. Professional obligation to treat others with the respect and dignity as you would have them show you. Refrain from behavior that includes intimidation. The organizational ethics statement, memorandum number 0-2A, states under 1B, WHHS is dedicated to the principle that all patients, employees, etc., are to be treated with dignity, respect, and courtesy. Number 1I, WHHS will conduct itself in a fair and ethical manner in its dealings with all healthcare providers, etc. I just want to say, last time these nurses from 2 West were coming to this meeting, there was a phone call made to their department by administration, and they were told by administration that if the nurses showed up to the board meeting, they would be severely retaliated against. This time, there was no such phone call. However, all 3 unions, we have a coalition of unions at this hospital, all 3 unions met together and they decided, yes, this was going on in all of these unions, the employees of these unions. So they handed out a piece of paperwork to educate the people that work for the hospital under these unions. And the people that handed out these forms were instructed, security was instructed to follow them, and they would drop off the forms and security would request the forms back from the employees saying they were told to collect that paperwork. I don't find that respectful at all. So I just wanted to bring that to your attention. Thank you.
Thank you. The next speaker is Tim Jenkins.
Oh, I guess security took my paper again. Anyway, so I'm Tim Jenkins with the California Nurses Association. You guys have seen me here before, and it actually saddens me to be here again because things have gotten worse, like several nurses have stated since we were here last time. I'm not going to rehash what they've already told you about firsthand. What I will do is direct you to the documents that I've provided you. One of the most important, I feel, is the patient safety survey which you have. because anecdotally, I hear this information, and so we decided to go to the Department of Health and Human Services website, do some research on non-punitive environments. And I think you all as healthcare providers in a hospital know that a non-punitive environment is essential for safe patient care. In other words, if our nurses see something that they feel is unsafe, they have to be able to feel comfortable reporting that to management in order for care to be the best in the community. And if they don't feel safe doing that, then you're not providing the best care that you could be providing. So if you look at the survey, you'll see that Washington Hospital is far below the national benchmark for a non-punitive environment. 17%, 15%, 9%, 8%. You can go on the website, you can read the national benchmarks, and you can compare Washington Hospital to the national benchmarks. And in the important safety features of do nurses feel safe in making complaints to improve patient care? The answer is no. And that's not the kind of hospital that I know you want, and that's not the hospital that our nurses want to work in. So the other document is a statement from the Coalition of Unions. I'd like to thank my union brothers and sisters who are here in support of us. Of course, thank all the nurses that have stood up in the back without seats for the last 45 minutes, or hour at this point. This is not a CNA issue. This is not a 2 West issue. This is a hospital culture issue. This comes from the top. And so here are requested remedies. The first, we want an independent investigation of the way administration has handled this. And what that means by independent is the union and the board mutually agree upon an independent investigator. We don't trust management to choose someone who's therefore going to say that they may be culpable. So one, independent investigation with anonymous interviews and immunity granted to the interviewees. We'd like that report published to the board and to the community. Because after hearing the stories I've heard, my feeling is if people feel safe to report what happened, okay, thank you, So I expect to hear a response from you all, and it's your fiduciary duty to this community to conduct that investigation and to conduct oversight of this hospital administration. Thank you.
Our next speaker is Nick Steinmeier.
Good evening, directors. My name is Nick Steinmeier. I am the union representative for ESC Local 20. Our union represents pharmacists, pharmacy techs, and clinical lab scientists at Washington Hospital. We also represent many other healthcare professionals throughout Northern California. Our union is here in support of the nurses and their struggle to obtain a non-punitive environment here at Washington Hospital, an environment where they feel they can raise patient care concerns without fear of retaliation. Hospital professionals, hospital support staff are the backbone of any patient care system, and nurses are the professionals that have the most frequent interactions with patients. Without them and other hospital professionals and support staff, there would really be no hospital. Our union is here on behalf of all hospital professionals and support staff at Washington and ask that you please direct your managers to work with CNA and any of the other unions to address these and any other concerns before patient care suffers further. Also, I would just like to point out that it is against the law for security officers to follow union representatives, and it is even further against the law to then confiscate materials that they pass out. Okay? That's a problem. Another problem I'd like to point out is that your security manager here was turning people away at the door. And when I kindly went over and told him, you realize this is a public meeting, that's a violation of the government code, the Brown Act, he was curt and extremely rude to me when I was just trying to point out something that he may not have known, to the point where I had to come in here and talk to one of your other administrators to take care of it. So I think If you like, I could come do one of those presentations like the first two you heard on the government code and the laws that cover these types of things. Thank you very much.
I apologize. Their last speaker is Akesan Molami.
Good evening. Good evening. My name is Axon Mulamai. I'm the union representative for SEIU-HWS. I'm here today to stand in support of the California Nurses Association for their goal of achieving a non-punitive culture here at Washington Hospital. I'm also here with a few of my members of our union here of SEIU from Washington Hospital and Alameda Hospital. Well, we're here today, again, to achieve a non-punitive policy because our union, as well as ESC Local 39 and other unions here at Washington Hospital, are in the same boat. We feel that Washington Hospital is not fair when it comes to employees for lots of different reasons. When employees have actual concerns regarding patient care, when they want to raise their voice to address simple matters. Now, I'm a union representative. It's part of my duties to represent an employee when they come in front of their managers, come in front of human resources. Sometimes this happens. Sometimes this happens when an employee comes over to HR. Now, a lot of times when this happens, an employee is yanked out of the floors, of a nursing floor, and a lot of times they cannot obtain a union shop steward or a union representative for representation. So not only are you taking someone off the floor, but you're also denying them their union rights to representation. Now, we all share the same goals here, right? Whether you work in housekeeping, in the kitchen, on the nursing floor, or in an office, we want to provide quality care to the patients that come through the doors of Washington Hospital. Now, as previously heard through the previous nurse testimonies, when an employee is scared of discipline or retaliation, we might lose sight of that goal. Now, we want to continue to provide that. So that's why we're asking for a non-punitive culture here at Washington Hospital. That's why we ask for dignity and respect. Thank you.
Unfortunately, Ms. Farber was very ill and was trying to come to the meeting, but she needed to go home. And I believe, Kimberly, you have a statement to read in her behalf.
Yes, thank you. As Madam President said, Nancy Farber had planned to be here tonight, but unfortunately she cannot make it. And she has asked me to read the following statement. I have a few things that I would like to address tonight. First, there's a higher authority here than CNA, hospital administration, or even the board of directors. The state of California and the federal government have enacted very strict laws that uphold a patient's right to confidentiality. The penalties for breaking these laws are costly fines for the hospital, as well as the potential for civil and criminal penalties available to the patient against individual employees who breach their confidentiality. Our own institutional commitment to the patient-first ethic requires that all of us are respectful of patients' rights, including the right to privacy. Because these laws have proved to be an issue in many hospitals and healthcare facilities across the state and the country, I instituted a requirement of mandatory education for all at Washington Hospital about the state and federal law. A zero-tolerance policy was also included as part of that education. Caregivers who are not engaged in a particular patient's course of care in this hospital are not allowed to snoop into the patient's medical records to satisfy their curiosity. It is known throughout the institution that unwarranted access of patient records can and will lead to termination. It gives me cold comfort that we are not alone in dealing with this problem. News media reported during Congresswoman Gabby Gifford's stay at University Hospital in Tucson, Arizona, that employees were terminated for just that behavior. There's another aspect of this matter that troubles me as it relates to the patient-first ethic. At the heart of the matter is a pregnant young woman who carried a baby to term, who, as far as she knew, would deliver a live baby. She did not. Regardless of what the coroner has found in this examination of this case, the fact remains that a young woman has suffered one of life's most painful losses. None of us should be tempted to embrace the morally or ethically bankrupt position advanced in the local paper that everything's okay because the coroner said so. No one here should trivialize the tragedy that has befallen this young woman. Inevitably, liability will be determined by the courts. Second, both the hospital and CNA are obligated to observe the terms and conditions of the contract that exist between them. If the hospital were to engage in a unilateral and selective compliance with the terms of the contract, the union would object. In this instance, it is the union who represents our nurses that has failed to repeatedly comply with Article 28 of the contract, which requires timely submission of grievances and stipulates agreed-upon timeframes. None of the grievances in question this evening were filed within contractual parameters. Some were several weeks late, and some were 3 or more months late. The real question that is before us tonight is not whether the hospital has treated CNA fairly, but rather has CNA fairly and properly represented the employees of Washington Hospital. Has this presentation tonight been orchestrated to divert attention away from CNA's own mistakes and inattention to duty? Our nurses pay over $725,321 a year for CNA for representation, which amounts to $2,175,964 for the duration of the contract. You might well ask why all of the contractual deadlines for taking action on your behalf have been blown, and not by a day or two, but by a whole lot. For the record, the hospital has already agreed to go to arbitration as it relates to the timeframes for filing grievances, which is at issue in many of the cases at hand. To the extent that CNA persists in allowing issues to remain unresolved, they make it very difficult for this organization to move ahead, focusing on what we are here for tonight and every day, patient care. Thank you.
We will now move on to written communications. Dr. Hensdorf?
Thank you, Madam President. We would like to recommend appointment for 2 new physicians, Dr. Jazeri and Dr. Liao. We're recommending appointment with clinical privileges as delineated from March 1st, 2011 through February 28th, 2013. We're recommending routine 2-year reappointments with renewal of clinical privileges for Dr. Belton, Dr. Bandari, Dr. Epstein, Dr. Kang, Dr. Lau, Dr. Liu, Dr. Nixon, Dr. Nyong'o, Dr. Puri, and Dr. Umena. We're recommending discontinuation of proctorship and staff status advancement for Dr. Say, pediatric hospitalist. And we're requesting that you accept the resignation of Dr. James Wolf in allergy due to low volume.
Dr. Hensdorf, with your concurrence, I want to postpone the action on the MEC's recommendation for approval of Dr. Umena until the next board meeting. At present, we only have 3 board members present. Dr. Nicholson has a conflict and may not vote on the MEC's recommendation with regard to Dr. Umena, leaving us with less than a quorum to vote on her approval.
I'd be happy to accept that concern.
Thank you. Thank you very much. Therefore, may I have a motion to approve the credentialing report with the exception of any action with regard to Dr. Umena?
So moved. Second.
All in favor?
Aye.
Aye. Motion passes. I'd like to ask the district clerk to put the MEC's recommendation for Dr. Umena on the agenda for the next board meeting. Thank you. Andy.
Good evening. Last year, I was honored to be installed as president of the Washington Hospital Service League. And I know I have said this way too many times before, but I am amazed and very proud of every single volunteer that offers so much of their time and efforts to help patients and their families at the Washington Hospital. I volunteered many years ago at the lobby desk, and I knew it was a very busy place, but I never knew how much was involved. Did you know that last year the lobby volunteers discharged over 9,819 patients. I learned about the volunteers in the Center for Joint Replacement from my friend and fellow volunteer, Jose Aguirre. Did you know that last year the CJR volunteers fed 2,279 lunches to patients and their family in the Center for Joint Replacement? You heard from Jeannie G. in the past, chairman of the Newborn Photography Program, about the photos that the volunteers take for the new mothers. Did you know that last year they took over 893 photos? How about what I learned about the remarkable women that comes twice a month to make baby bonnets? We all know what baby bonnets are, right? The thing that goes around the head. Okay. Did you know that last year they made 2,034 bonnets, and they also made 2,594 puppets for the children in the emergency room? I learned about the patient feeders, a program that started in December 2000. It takes a very special person to do this job, and even though we just have a few volunteers feeding patients, did you know that since December 2000, the volunteers fed over 3,056 patients? I could talk about each and every service and each and every volunteer, and it would take me all night to tell you about all the service that they provide, that are provided by the volunteers. All of this looked very easy to me, but I had no idea how much effort and dedication it takes to get the whole job done. I can tell you that it takes a very special group of people to accomplish this work. Did you know that last year it took over 50,000 volunteer hours to provide services staffed by volunteers at Washington Hospital? I didn't think that being the president of the Service League will change my life, which it did. Meeting so many dedicated volunteers make me very proud to be their president, and I am looking forward to being installed again as the new president next Monday. I am more than humbled by the position, and I will continue working hard for the Washington Hospital Service League.
Thank you.
Thank you.
I'm glad to hear that you're going to have another term. It seems to be kind of common with the group. It's a
Yeah, it
two-year
almost
commitment.
takes
Yeah.
1 year to learn the job to do, to be continued the following year.
Well, I think you've done a splendid job the first year, and I know you'll do even better the second year.
Thank you. Thank you.
Oh. Very apropos. Dr. Hensdorf, you're on again.
Thank you again. We currently have 505 members of the medical staff, 360 of which are in the active category. We have sent out recently pre-applications for 10 physicians, including physicians in internal medicine, pediatrics, plastic surgery, pediatric dentistry, family practice, rheumatology, and gynecological oncology, reproduction, and endocrinology. We have 6 applications currently in process in the areas of family practice, OBGYN, internal medicine, and a physician's assistant in surgery. We have the 2 applicants that we forwarded to you this evening. We're anticipating sending 10 new applicants to you at the meeting of March 9th, 2011. One is a physician's assistant in medicine. The others are in internal medicine, pediatrics, teleradiology, plastic surgery, general surgery, OBGYN. And that ends my report.
Thank you.
You're welcome.
505.
505. Each month we go a little higher.
Do you remember how many physicians we had on staff when you first took office this time?
When I was a chief of staff the first time, we had approximately 240. And when I became chief of staff this time, I think there were approximately 460. So we've been
That's
consistently gaining.
Quite a growth. Thank you very much.
You're welcome.
We're going to start with Ed Fain giving the construction update.
Kimberly. So we'll pick up where we left off last month. Both projects, the CJR and the Center for the Central Plant, are continuing on schedule and continuing to stay under budget. So what we have here is the beginning of radiators being brought to the site, and these are the radiators that take off the heat from the emergency generators. I think we talked about this a little bit last time, so they've been placed, and plumbing put in place, taking that will transfer the heat off to these from the emergency generators. There's a few things that we may have shown you in the past, but basically all the covers and all the visqueen and everything is starting to be taken off some of the equipment, and it's being tied in. So this is just a quick shot of the main electrical switchgear in the middle of the central plant, that all the electricity throughout the house from PG&E will come here, all the transfer switches for emergency power. So this is sort of a hub for electricity in the central plant. These are two other sets of boilers that you can see. The plumbing and piping is starting to get tied into these, and this is for hot water generation, both domestic hot water and then also some heating hot water. This is the control room, so all the alarms, be it fire alarms, gas alarms, anything that's going to be alarming, all the equipment that is in the plant has an alarm system that will be in the central station here, that it'll be monitored. It can be monitored and checked at any time. I just put this in here to show you that finishes are going on in here. We have carpet in, we have tile in, things like that. So the central plant is actually getting very close to a finished product. We can move on to the CJR, and this just gives you a shot of the roof. So the good weather that we've experienced through most of January and into February has allowed us to put both the waterproofing and the roof membrane onto the CJR. This gives you a little shot of the, we've talked about this a couple of times. This is, again, the corridor that will be the connecting corridor between the main hospital and the CJR, and this is the grade beam work that has gone on and has been poured since the last time that we showed you this. You can see the bridge now has, all the steel has been erected, connecting the two buildings, and decking has been put into place, so this is also moving forward quickly. This just gives you an idea that the interiors of the first floor are being framed in and work. This is a shot of actually one of the head walls has already been put in place for one of the patient rooms. You can see just with drywall starting to go in, and a lot of the plumbing is being put in place. This is just plumbing coming out of bathrooms, so we've got infrastructure that's being completed. And then if you've had any time to walk around the outside of the building, you can see that the as I was corrected last time, bowed window is going into place, and so we're getting actually the curtain wall is today completed, and so we're making good progress there. I just threw this in here. You can see the insulation on the pipes. This is part of the what was one of the projects that was tied to the central plant that was called the Utility Connection Project. And actually, it was the suggestion of Swinnerton that while this is the final part of this central plant project, which is tying into the main hospital, it was their suggestion that instead of waiting to the end, that we actually do all this work up front so it's completed and we're not worrying about when it comes time to commissioning, there's not a concern about are we all tied in. So basically we're down to the valving stage at each of the different tie-ins in the central plant. So we're basically, as soon as the utilities are ready, we're basically ready to tie in. So that was, I think, a good move, and again, will keep us ahead of schedule. That's it. Any questions I can answer from the board?
We're on schedule?
Yes.
Are we ahead of schedule?
we're actually still ahead of schedule.
And on budget?
And we're still on budget, correct.
Well
Very
within
good.
our contingency.
Well within, yes.
Very good.
Moses, you had a question?
Quick question. You may not know the answer. Do you know what is the lifespan of a membrane roof on top of CJR? How long does
Oh,
that
gosh.
usually last?
Well, it's considered to be the latest and best technology, and I think they have a life of something like 25. It's either 25 or 30 years. So it's considered to be the best, even though it's a little bit lighter and not as thick as those and heavy as those built-up roofs. Has as good or better life, and a key thing, easier to fix punctures in it. Find and fix punctures if any occur, which is a big problem on a built-up roof. You have to basically tear the roof up to find it. Okay.
Are
Thank
there
you.
any other questions? Thank you, Ed.
Continue with the calendar. On January 14th, there was a community education program called Look Good, Feel Better at the Washington Women's Center. Nestle Moquette was the representative from the American Cancer Society who moderated this presentation, and 5 people attended. This had a maximum capacity of 8. January 14th and 28th, and as you will hear through many days in January and February, we had a hand hygiene presentation at Pioneer Elementary School. And Lucy Castillo, our operations coordinator at the Community Health Resource Library, did that presentation, and 78 students attended. On January 20th, we're very proud that we had the opening of the Washington Center for Wound Healing and Hyperbaric Medicine. 100 people attended this open house, and it was really for the community to learn more about the Wound Healing Center, and now that we are offering hyperbaric medicine. And so get everybody to either go on the website and learn more about it, or to get over. It's at 39141 Civic Center Drive, Suite 106. On January 22nd, we had the 5th Annual Women's Health Conference, Embrace Health, Feeling and Looking Your Best. We had it was 122 people in attendance, and we had over 10 people that different physicians presented different areas relating to women's health. On January 27th, the California Hospital Association issued a memo that the Department of Health Care Services has given notice to implement a rate freeze authorized by Senate Bill 853. It also requires the Department of Health Services to implement a new payment methodology for inpatient hospitalization based on diagnosis-related groups no later than June 30th, 2014. And also, the rate freeze shall apply to inpatient hospital services provided to Medi-Cal beneficiaries beginning July 1st, 2010. And it's just significant in terms of understanding, given the budget circumstances at the state and federal level, that we're beginning to see rate freezes or looking at reductions, that we will be analyzing the impact moving forward on the healthcare system. Also on January 27th, there was an announcement that Mr. Calvin Knight became the president, was selected as the president and CEO of John Muir Health, and he is coming from Swedish Health Services in Seattle, Washington. So in terms of just announcing that. January 31st and February 4th, we did additional hand hygiene presentations at Sara Lee's Elementary School in Union City, and 104 students attended that. On February 1st, again, we did another hand hygiene presentation at Grimmer Elementary School. We had 28 students attended. On February 1st, again, we did community education, cough and pneumonia, went to see a doctor. Dr. Samir Vora, a pulmonologist, presented this presentation. And lastly, on February 1st, stroke program, Life After Stroke and Future Diagnosis and Management. 10 people attended, and Dr. Ravinder Kalan, neurologist, and and Doug Van Houten, an RN and coordinator, presented this program. February 1st and 2nd, we had Holland and Knight. They're a legal firm out of Washington, D.C., and lobbyists that came and educated the management executive staff on the Affordable Care Act, really understanding better in terms of what we know now and potential future regulations in terms of what will be implemented. So had an educational session on a day and a half for the management team. On February 3rd, there was a presentation, Keeping the Beat, Heart Health for People with Diabetes. 35 people attended, and it was given by Dr. Jeffrey Carlson, cardiologist. February 7th, we had a community outreach, another hand hygiene presentation at Glancler School in Fremont, and 25 students attended. February 7th, Exercise for Your Health was a presentation given at the Washington Women's Center, and Sherry Harrington, respiratory care technician, presented this, and 14 people attended. We had on February 8th a Speakers Bureau for Career Day, and this was at Newark Memorial High School in Newark. We had Lynn Franks, RN and certified diabetes educator, our own Pat Danielson, RHIT was there, along with Ruth Trailer, who was our Director of Community Outreach, and Nakal Bangle, who is a certified registered dietitian, all presented on Career Day, and looks like we had over 120 students that attended. So it sounds like it was a very successful event there in Newark.
Thank you.
February 8th, we had Community Education, Ankle Conditions, and the Latest Treatment Options presented by Dr. Joshua Van Gompel, podiatrist, and 55 people attended. Also on February 8th, we had a hand hygiene presentation, and also on February 9th, we did two again at Breer Elementary and Cabrillo Elementary School, and 24 and 43 students respectively attended. So as you can see, we're very much been out in the community around hand hygiene for the students. Moving on to upcoming presentations and community outreach. On February 15th, we have community education, health insurance options, what you need to know, from 10 to 12, and Linda Dwall and Christy Caracappa, our health insurance information service representatives, will be giving this education session. Also on February 15th, heart surgery options, coronary artery disease, and what is cholesterol and how to lower it. This will be from 1 to 3 p.m., and Dr. John Cecil Walks, who we heard tonight, will be the main presenter, along with Dr. Michael Parmley, internal medicine. On February 16th, we will have a presentation, low-fat cooking demonstration from noon to 1, and Anna Mazai, our clinical registered dietitian, will be presenting this lecture. On February 22nd, community education will be balloon sinuplasty from 1 to 2:30 p.m., and Dr. Piali Dadarai, ear, nose, and throat physician, will be presenting this seminar. On February 25th, we'll have a community outreach, Fremont Chamber of Commerce Career and Community Resource Fair from 8:30 to 12:30 p.m. at the Fremont Adult School. And we will have Christy Caracappa, who will be representing the hospital at this event. February 26th, we will have community outreach, the second annual Tropics Health and Resource Fair for seniors, and this will be at the Tropics Mobile Home Park in Union City. On March 1st, community education will be elder weight management and simple nutritious menus from 1 to 3 p.m. and Dr. Tan Liu, family practice medicine, and Anna Mazai, a clinical registered dietitian, and the two of them will be presenting this educational session. March 1st, we have a stroke program, Introduction to Stroke, Risk Factors for Stroke, and Dr. Ash Jain will be the presenter, along with Doug Van Houten, who is the coordinator. On March 3rd, we have 3 different speaker bureaus that are happening. The first is nutrition, and this will be happening at the Afghan Care Veterans Hall in Fremont. Makaria Meyer will be presenting this. Also on March 3rd, Health Insurance Information Service will be doing a presentation at the Fremont Family Resource Center from 10:30 to 11, and Christy Caracappa will be doing presenting this lecture. And also lastly, on March 3rd, we will have a Diabetes Matters class, Partnering with Your Doctor to Improve Diabetes Control, and that will be from 7 to 8 p.m., and Dr. Diane Martin, Internal Medicine and Infectious Disease, will be presenting this lecture with Vida Reed, our diabetes coordinator. Moving on to March 4th, community education, osteoporosis, and fall prevention from noon to 2, and Dr. Barry Shibuya, rheumatologist, and Maureen Parent, coordinator of Life Elder Care Fall Prevention Program, will be presenting this seminar. Also, on March 8th, we have World Kidney Day from 1 to 3 p.m. We have Drs. Jeffrey Carlson, cardiologist, Ki Chi, nephrologist, Cecilia Sun, registered dietitian, and the three of them will be presenting this ceremony, along with Dr. Lucy Jimena, who will be moderator of it. And those are the community education seminars. Then in terms of the foundation, on just some updates, on Monday, January 24th, the foundation held its annual general meeting where it presented Pathways Home Health and Hospice with a check for $85,000. Comprised of proceeds from the golf tournament and Trees of Angels campaign, this donation is the largest amount that the foundation has ever gifted to Pathways to support hospice care in Washington Township. It was a great event. The foundation president, Demetra Schaefer, also presented Washington Hospital with a check for $638,463.90 to support a wide variety of clinical services and technology for patients. At the meeting, the foundation board welcomed aboard 10 new trustees and bid goodbye to 8 who have completed their final term. So we really appreciate all the support that the foundation gives to the hospital and the healthcare system. Moving on to Washington on Wheels Mobile Health Clinic. During the month of January, Washington on Wheels Mobile Health Clinic continued to serve the community members at the Fremont Senior Center, the Family Resource Center, and the Silliman Activity Center in Newark. In addition, WOW provided healthcare services at school sites including Brewer Elementary, Grimmer, Walters Junior High, Irvington High School, Kennedy, and Mission Valley ROP, all located in Fremont. And lastly, the WOW provided sports physicals for students at Mission San Jose and Irvington High School. In terms of our internet marketing for the month of January, Washington Hospital website had 33,404 visits and 21,564 unique visits, which resulted in 109,205 page views. Some of the most visited links on our site were included the employment section, followed by the physician finder. InHealth was very busy in January with InHealth staff completing taping of a Diabetes Matters program, Keys to Healthy Eyes, a health and wellness class entitled New Techniques for Treating Back Pain, and capturing all of the presentations at the 5th Annual Women's Health Conference. In addition, staff produced a video that shows the new hyperbaric chambers at the recently opened Washington Center for Wound Healing and Hyperbaric Medicine, and commenced production on another hand-washing music video called Germ Busters, which features Washington Hospital's medical staff. It's one of those that it uses the theme song to Ghostbusters and features several of our physicians. And I know many of us are awaiting the unveiling of that video. Also, InHealth captured the Citizens Bond Oversight Committee meeting, as well as other productions of Inside Washington Hospital. In terms of WIA, the WIA-sponsored ski resort tickets to North Star and Sierra Ski Resort are now on sale, and tickets have no blackout dates, so they're good for the whole season. To date, 48 tickets have been sold. And lastly, moving on to Employee of the Month for February, it's Thassani C. New Anderson. Thassani has been with the Environmental Services Department since she was hired in 2000. She's very dedicated to her job and brings joy and compassion to the people she meets, especially the hospital patients. Thassani does her job to the best of her ability, with a smile and without any complaint. Thassani comes from Thailand and is very proud of her son, her country, and her family.
Thank you, Kimberly. I have one point that I'd like you to clarify.
Okay.
I was one of those people that was on the website, one of those many numbers.
Yes.
And with my new computer, I was able to watch the video on hand washing.
Right.
So there's another one being made as well?
Yes, there is another video that is being made, and it features physicians. So there will be another video. And so our website recently was upgraded in terms of now the technology you can watch on your handhelds or on your computer, the videos, including the hand washing video.
I thoroughly enjoyed the video on the hand washing that is on there now, and I would encourage all of our viewers to check it out. There's quite a bit of talent within the hospital family, and I look forward to the next one that's going to be done.
Yes.
So it was a hoot.
It's been I know many of the employees enjoyed making that.
They looked
video.
like they were having fun.
Yes.
They really did. And just one other point, Andy at Career Day, Ruth and I made a point out of telling all of these lovely young students who wanted to look into a healthcare field to check out the hospital volunteer program, because we told them that this was the best place to find out, and that was the best way to find out what it was really like here. So I hope a few of them heard us.
They did mention that to me in the past, you know, like last week, especially college students.
Yeah.
They did
Well, these were the
mention
high
that.
school students,
Yeah.
and there was a number of them that were, as usual, were really, really interested. So I'm hoping some of them will come over here and become a part of your program. Comments, gentlemen? No? Okay, thank you. I guess we can go on to quality reports. Daphne Williams?
Thank you, Pat. Tonight, the focus is going to be on the hospital-wide quality activities. And I am going to be describing how Washington Hospital selects quality measures for performance and process improvements. Our CEO, Nancy Farber, believes that quality is everyone's responsibility. So therefore, quality is a hospital-wide responsibility involving every department. Quality can be financial, it can be clinical, and it can be service-related. So all areas of the hospital participates in quality improvement. We monitor our performance on an ongoing basis because it lets us know how we are doing. We are able to maintain our goal of best practices. Our patient-first ethics are focused on providing the best possible care every day and ensuring that each of our patients is satisfied with the care they receive. So that's one of the reasons why we choose some of the quality measures that we do. We also believe that there is always an opportunity for improvement. And by closely monitoring, assessing, analyzing our data, we will continually strive to improve the care we provide to our patients. So how do we get started? Every department in every division has a blueprint. The blueprint is a performance improvement plan or a roadmap. It consists of a list of relevant department indicators. And the indicators are quality measures. What are we going to be looking at? These indicators are monitored systematically over a period of time. Our indicators are compared to established standards, both national and within the organization. And we have action plans that are developed to improve our performance, to improve our care. So how do we choose what indicators we are going to be measuring? First, we look at what's out there in the literature. That is evidence-based. And to do that, we look at IHI, which is the Institute of Healthcare Improvement. We look at best practices as it relates to societies like American College of Cardiology, the Society of Thoracic Surgeons. Those are just a few of the areas that we look at. We review and analyze our previous year data. We look at what was best practice, what we did well, we try to replicate. If there are areas that needed improvement, then we come up with action plans and they go back again on the blueprint for the coming year. We review the risk reports, compliments, and complaints. This accounts tell us what our patients, staff, and physicians are thinking. Anything that comes through a risk report or compliment, if it does have an impact on the quality of the care we provide, it's incorporated into the blueprints. We look at organizational activities. We review those activities. Did we meet our goal? Is it something that we want to continue? And if we weren't meeting the goal, then it goes back on that that indicator goes back on the blueprint for the coming year. And we look at new regulation with CMS, Joint Commission, the state. We look at any regulations that may have an impact on the care we provide to our patients. So what is our process for review? The Quality Steering Council establishes yearly priorities. This committee consists of senior leadership, the CEO, the medical staff leadership, and is chaired by a board member. The departments review and evaluate their specific indicators. Nursing uses the shared governance and the unit-based council for their evaluation of their indicators. Once these indicators are approved by the staff, it goes to the chief or the head of the division for approval. The Quality Steering Council drives our quality initiatives from an organizational level, while the department drives it from a unit-based level. Now, where does the results go? It goes to staff meeting. It goes to the chief's quality meeting, and that's the work group. And that's where all the chiefs meet, review the data, analyze the results, look at the action plan. Is the action plan meeting the intent in terms of looking at a probable solution? It then goes to the Quality Hospital Physician Advisory Council, also known as QHPAC. And on that committee sits medical staff, senior leadership. From there, it goes to the Quality Steering Council. The chair of the QHPAC is also a member of the Quality Steering Council, and that data is reviewed by that committee. That data is also disseminated to the medical staff. It goes to the Quality Resource Management Committee, and the Chief of Medical Staff Affairs, a physician, reports there to that committee. So let's talk a little bit about some of the results in terms of what we're seeing from an organizational standpoint. These are some of the areas that oftentimes you don't see because we tend to report a lot of the clinical areas. Let's look at what human resources is looking at. This is just one of their indicators. They're looking at the annual turnover rate. The national turnover rate is 15%. Our rate is consistently below the national benchmark. If you look for fiscal year 09 to 010, our annual turnover rate is 5.4%. We have an excellent retention rate, which shows that the majority of our staff likes working at Washington Hospital. The volunteer department also does quality, and this is one of their indicators. They look at the number of volunteers who have completed orientation over the number of volunteers who attended information sessions. And up is good, and they are improving. Employee health, this is one of the indicators, reportable work injuries. We have a robust worker safety program. We have a multidisciplinary worker safety committee. And some of the things that we have implemented are a lift team, ergonomic evaluation of employees' work areas, and needleless system to help prevent needle stick injuries. And again, down is good. And you have seen we are consistently better than the national benchmark. Laboratory service. One of their indicators is critical values within 10 minutes. These are the results and tests that makes a difference in terms of how the physicians care for patients. The goal is 10 minutes. And you see we are consistently at 100%. The quicker we get these results to the physician, the better care we provide to our patients. Case management. One of their indicators is an important message from Medicare. This is a letter that's given to all Medicare beneficiaries, and it basically describes what service they are entitled to and the appeal process. This is given to them on admission and it has to be given to them within 48 hours of discharge. This allows them to appeal their discharge if they feel that they are not ready to go home. If this is given to them with a window longer than 48 hours, the letter is reissued to the patient. The goal is 100%, and we have been meeting that goal. And this is one that CMS does monitor. The admitting department, they look at condition of admission, which is consent for treatment. Every patient coming to the hospital before they get treated, either them or their patient representative must sign for treatment. Again, this is the goal, must be 100%. Central registration, wait times. This was an issue at one point in time for us. We took it seriously. The goal now is less than 6 minutes. And you see, consistently, the Central Registration Department has been meeting this goal. It's under 6 minutes. Food and nutritional services. This data is from PRC, which is the patient perception of the satisfaction with the food we provided. They have done a lot of work in the food and nutritional services. They are making sure that the patient gets the food at the right temperature. Because of our ethnic diversity, a lot of the menus are incorporating ethnic food. This is good. Nursing response to call light. This again is PRC, a patient satisfaction perception of patient perception. This is one that we did a lot of work with. At one point in time, this result did not look this good. There is a task force that looks at this on a monthly and weekly and daily basis. And there is also incorporated early rounding, so frequent rounding with the patients before they have the need to call. These are just some of the indicators from the other departments as it relates to our quality activities. And in the coming months, I am going to be showing you from different indicators from different departments. Any questions?
Thank you, Stephanie. I believe we're ready for our finance reports from Chris Henry, our Chief Financial Officer.
Okay, tonight we'll be looking at our operating and financial results for December 2010. We're still living in 2010 in finance. Our average daily census for the month was 10.7 above budget at 184.8. We had 1,066 admissions, 42 less than the budget for the month. However, patient days were 333 above the budget at 5,729. That implicates the longer length of stay that we're reporting down below here. Our average length of stay for the month was 5.12. We had expected 4.87 for the month, so patients are staying longer in December. Moving into our utilization, case mix index remained high in December at 1.465. Deliveries were 30 below budget at 158. Surgical cases were also 41 below budget at 333. That includes our joint replacement cases that were 9 below budget. Neurosurgical cases were 5 below budget, and cardiac surgical cases were 10 below budget for the month. PTCA procedures, however, were 14 above the budget at 78, and cath lab procedures overall were 35 above budget in December. Outpatient visits were pretty darn close to budget at 8,464, and the emergency room continues to beat our budget with 141 more visits than we expected, coming in at 4,274. Looking at our productive FTEs for the month, we had 1,383.4. Non-productive FTEs came in at 208.9, giving us total FTEs 100 even above budget at 1,592.3. Our full-time equivalents per adjusted occupied bed, which is our productivity measure, came in pretty close to budget, at just slightly under at 6.76. So that's a good indicator that we were staffing correctly for the activity in the house. Moving into the financials, as always, we'll look at the Governmental Accounting Standards Board presentation. For those who aren't familiar with this, this is the presentation used for our audited financials. Total patient revenue for December came in at $7,362,000 above budget at $159,137,000. Of that, we wrote off 73.63% to our contractual obligations and ended the month with net operating revenue a little under $2 million above budget at $42,251,000. Operating expenses for the month came in $1.568 million above the budget at $39,514,000. We saw those variances, of course, with salaries and wages with our higher level of FTEs. Purchase services and pro fees came in above budget for the month, as did our provision for bad debt and charity. That was about $500,000 above budget. So we end December with an operating bottom line, $379,000 above the budget at $2,737,000. Non-operating for the month, we actually posted a non-operating loss for the month, largely driven by a $3.8 million unrealized loss on our portfolio investments. That is something that by definition is unrealized. We've all been hearing about the swings in the bond market, and that what happens is when the equity markets start to improve, and they have improved significantly over the last year, investors start demanding greater returns, and that tends to have a depressing effect on the market prices of fixed income securities that we hold. But again, it is unrealized. It wouldn't have been realized unless we had sold our entire portfolio on December 31st, which of course we did not and don't intend to. We tend to hold our investments to maturity, which really mitigates any of those losses in the end. So we end up with a total bottom line from a Governmental Accounting Standards Board standpoint of $385,000, about $3.2 million below what we expected, but again, that largely driven by the unrealized loss. I wanted to take a quick look, given this, at what our investment returns have been over the last several years. Really pretty consistent, and even this year with these unrealized losses that we're posting, our total return on our portfolio is positive. And this again is just a testament to how well we have weathered this financial storm that has been circulating on Wall Street. So overall, we've done very well. And that's why we like to look at the Financial Accounting Standards Board presentation. This is the way Wall Street looks at us. Wall Street recognizes that the losses on market value of our investments is unrealized, so they don't consider it. So for this presentation, we pull that unrealized loss out, as well as our GO bond revenue, which we use to service our GO bond debt. And we end up actually with a non-operating income of $745,000 and a total bottom line from a FASB perspective, almost $3.5 million. So are there any questions on December? Okay.
Thank you, Chris.
All right, moving on to the hospital operations report. The month of January saw 1,167 patient admissions that resulted in 6,508 days of care. The average daily census in January was 210. This average daily census was higher compared to December's average daily census of 185. January's high and low census was 247 versus 170 respectively. And I just do want to comment on that because you probably heard in January we had a high census of about 281, but there are, we do not log in our average daily census those patients associated with observation or the special care nursery. So yes, they're here in-house, we're providing the services, but they're not counted in our census. So we had a number of days in January where we were at a high of 280. The average length of stay for adults and children in January was higher than budgeted at 5.05. The budget anticipated an average length of stay of 4.89. Patient mix, preliminary information indicates that inpatient revenue for the month of January amounted to approximately $134,256,043 compared to the budgeted estimate of $129,425,457. Of this amount, 50.7% was Medicare, 11.5% was Medi-Cal, or a total of 62.2% program revenue. Births. The birthing center saw 170 deliveries in January compared to the budget of 203. January's deliveries resulted in 383 baby days, and newborns totaled 174 for the month. Surgery for the month of January, there were 335 surgical cases at the hospital versus a budgeted amount of 403. 529 cases were seen at the outpatient surgery center versus a budget of 556. For the month of January, there were 375 cases seen in the cath lab, including 51 PTCAs. Total cath lab cases were higher than budget by 23 or 6.5%, and PTCAs were lower than budget by 16 or 23.9%. Outpatient visits for the month of January had 9,136, were above the budget of 8,945, and higher than the January 2010 visits of 8,875. In terms of emergency room and clinics, the emergency room recorded a total of 4,553 patients, a daily average of 147 versus a budget of 4,394. The Washington, Warm Springs, Newark, and Nakamura clinics saw approximately 4,224 patients during January. Total system emergency room and clinic visits for January are 8,777 compared to a budget of 8,817 visits. In terms of personnel, we had full-time equivalents for the month of January totaled 1,596, including 49.7 agency personnel. So in summary, January had 1.9% fewer admissions and 12% more patient days than anticipated in the budget. Total paid FTEs were above budget by 22.2 or 1.4%. Inpatient charges for the month were higher than budget by 3.7%. Outpatient charges were below budget by 4%. The total hospital charges for January are above the budget by approximately 2.1%. On January 31st, there were 170 days cash on hand. The total days revenue and accounts receivable at January 31st was 77. During the month of January, $2,281,280 of charges were approved for charity assistance. Thank you very much.
Thank you, Kimberly. We're now ready for action items. Dr. Nicholson?
Item A, Madam President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the Center for Joint Replacement's second floor build-out change order for a total amount not to exceed $9,335,883.
Second.
Do we have any additional comments? Ed?
Yes. This is a change order in lieu of going through public bidding for the second floor, which is what we would normally do, but we don't believe that that will provide us with the greatest public benefit. There's potential construction risks, adverse impacts to CJR operations, and there's controls for price reasonableness that we can put in place. And just briefly, if we went out to bid on this, if we didn't use the same general contractor that we have all the mechanical, electrical, plumbing that has to be connected between the two floors. And so we have the issues of the difficulties in trying to do that with two separate contractors and subcontractors. We have the issue of if we had to wait until getting somebody else in here, we'd have to demolish work that is going in the first phase, brand new, to put in connections for the second phase. And then you have sort of the opening up the whole liability of allowing two subcontractor groups, two general contractors, and the possibilities of both groups pointing fingers at each other. We obviously have the issues of putting patients in the area and then having work going on right above them, which we don't want to do. And then finally, we're going to be getting an outside estimate for the work, getting a price from Swinnerton, who's doing the first and second floors, and thereby we will have ability to compare. We will then be able to negotiate to get competitive pricing. If that doesn't work out, we can then make them go and get competitive bids from other subcontractors if it gets to that. So this is the reason for the change order, and this is the reason for the request.
This
Thank
has
you.
been reviewed by hospital council.
Absolutely, this
and-
is all on the recommendation of hospital
and
council.
Falls
Thank
well
you.
within the scope of the law.
Yes.
Yeah, thank you.
Great, thank you. We have a motion and a second. All in favor?
Aye.
The motion passes. Thank you. Next.
Item B, Madam President, I move for adoption of resolution number 1102, construction related to operating rooms number 1 and 2, and in accordance with district law policies and procedures, that the chief executive officer be authorized to purchase Brain Lab navigational equipment for an amount not to exceed $2,890,000. This equipment was not included in the fiscal year 2011 capital budget.
If I can provide some information. This is a two-part motion, so let me first talk about the construction-related costs of OR 1 and 2. This is a project that's been long in coming. These are the oldest ORs in the operating room, and we want to turn or be able to provide advanced neurosurgical and spine surgery capability at the hospital. So our plan is to turn one of these two ORs into a neurosurgical suite, accommodated with larger monitors, accommodations for a software package called Global Care Quest that will allow all clinical information to be put on large screen monitors on walls, reorient the room 90 degrees, and add LED lights and booms in room 1, and then in OR 2, create a orthopedic room that will have that will be enlarged, put in laminar flow, and accommodate advanced laparoscopic equipment. And the costs for this project are $3,632,822, and that's part of the resolution. Secondly is the Brain Lab navigational equipment, and I thought it would be a good idea to invite Dr. Moses Tagioff to make a presentation about the Brain Lab navigational equipment so that I think members of the community can learn what type of advanced capabilities we're planning on putting in these ORs. So Dr. Tagioff is a long-term neurosurgeon in the community with obviously had a very large community practice. He currently is Medical Director of Strategic Surgical Services at the hospital and Chairman of the Operating Room Committee, and I'd like Dr. Tagioff to make a presentation about Brain Lab.
Members of the Board of Directors, Ed Fay and Kimberly Hartz, esteemed Chief of Staff, Jan Henstorf, Andy Estevez, ladies and gentlemen. I know it's late, so I'll move on quickly. If you fall asleep, go ahead, I'll understand why. In 2007, there was a total of 72 million CT scans performed. You heard me right. 72 million CT scans performed in the United States. 3 years later, now I would imagine that the number has exceeded 100 million. This evening, we're not going to discuss CT scans, but we're going to talk about what we do with the CT scan finding once we find the problem. Discussion tonight is about navigation, neuronavigation. That's what it's all about, getting there safely, expeditiously, and precisely on target. 5 years ago, I was called by the emergency room to see a patient, our dearly departed Taylor McAdam Bell. He arrived there severely confused with his malignant brain cancer. I was initially reluctant to do his surgery here. Not that I lacked the skills, but I was concerned about conducting his surgery safely and giving him the best chance at a quality survival. I tried transferring him to UCSF. The neurosurgeons I sought were not available. Besides that, Taylor McAdam Bell was very reluctant to be moved. And as a result, I took him on Sunday morning with my dear friend and colleague Desmond Erasmus, and we did a gross total removal of the worst kind of malignancy a human being can suffer from. Having a glioblastoma multiforme is a death sentence. Untreated statistics show that the average survival without treatment is 12 months. With very aggressive treatment, it's 13 months. You really don't gain much. Fortunately, Taylor Bell lived after his surgery for 4 years and actually came back to work for us as the hospital counsel after his surgery. My reluctance stemmed from the fact that I feared I may not get a safe gross total removal. We don't know when we've taken the tumor out completely. That's because in our institute we do not have an intraoperative MRI scan or a CT scan, and we have neuronavigation, but it's not as precise as what I'm proposing. The neuronavigation system we are discussing now is called BrainLab. Next slide, please. Neuronavigation is a neologism, which means it's a new made-up word. It is a process of computer-assisted technologies where we as neurosurgeons and orthopedic surgeons use it to get to the target precisely and safely. This could be done within the confines of the skull or the vertebral canal. Navigation can also be used more universally. You don't have to be a neurosurgeon or an orthopedic surgeon. It can be used for ENT, general surgery, urology. And the company that we are talking about that I'd like to introduce you all to is called BrainLab. BrainLab was born in Munich, Germany in 1989. That time, Stefan Wilsmeyer, a brilliant young engineer, was given a broom closet to work in. He began working on his mouse and managed to create software for surgical planning in navigation, with navigation. In 1994, BrainLab was established in the United States. Today, BrainLab is an innovator, an award-winning innovator of image-guided surgery, and has been acquired by just about every major hospital in the country, including the Cleveland Clinic, UCSF, UCLA, Mayo Clinic, Johns Hopkins, etc. The key clinical issue is not just to identify your target at surgery, but to identify changes that occur during surgery while you're operating. Now, you have to understand that when you start removing a brain tumor, the brain moves. Don't change it yet, please. Go back. The brain moves. Here is the image-guided probe going down, not quite to the tumor. Here's the tumor. But here's the image-guided probe. And here it is. After the tumor has been removed, you see the brain has, that's the skull up here. This is the brain, and the brain has moved because this tumor has been removed. What BrainLab does is it constantly monitors the movement of your brain as you're removing the brain tumor. And mind you, in brain surgery, millimeters are important. You cannot miss your target by millimeters. The brain shifts, and this occurs while operating, and the BrainLab system will modify and will read the shifts automatically. The key word in this slide is automatic. At a recent visit we made to a hospital in Arizona, we were told that of the 2,000 pedicle screws that were inserted by the spine surgeons in Arizona, only one screw was misplaced. When your screw is within the pedicle is a tube of bone, the screw has to go exactly in the center of the tube, precisely. When it's not within the tube, all sorts of complications can occur. You can get nerve injury, paralysis, spinal fluid leaks, infections, meningitis, etc. Also, nothing is more disturbing, even in the best of hands, when the surgeon opens the skull and finds that the tumor is not under his opening. Believe me, it happens to the best of us. So you make the opening here and the tumor is here. You got to go back and start probing the brain to look for the tumor, which is very destructive for the patient. You go back to the intensive care unit, and then you do a CT scan and you find out, my God, the boundaries of the tumor were not well defined and I didn't quite get it all. Fortunately, even though we did not have the monitoring that we needed, Taylor McAdam Bell's tumor was grossly and totally removed, which gave us precious 4 more years of his life. Knowing that one does not get back to the OR makes the 3 Ps, the patient, the physician, and the payers, extremely happy. They don't like going back to the OR, and neither do we. Next slide. The 2 major building blocks of the system that we are requesting are here. One is called Vector Vision Sky, and the other is called the Brain Suite. The reason the word sky is given to Vector Vision is because it comes down from the sky. And that's very important. It's a monitor which comes down from a boom in the ceiling. It cannot go from room to room, it stays in the room. And it can be adjusted by the surgeon so that he can view the monitor clearly. Because of the sky approach to the operating room, there is no clutter, there's no tripping over wires and tubes, and bringing down sterile microscopes that fall onto the field and destroy the entire operative field, which I've seen happen. It's happened to me when I was in England. The second component is the Brain Suite Net, which is the one on the right. The Brain Suite Net is the central nervous system of Brain Lab. This is where your $2 million worth of software is going to be lodged. The Brain Suite Net sits on a separate boom, also coming from the ceiling. The Brain Lab software speaks to all these entities. It speaks with CT scanning. It can talk to an MRI scan that has been previously done. It can talk to an angiogram. And Brain Suite actually can provide you with all of this integrated in one operating room. We're not doing that. We're getting the Brain Lab without the CT scan on rails. We believe that CT scan is much better than getting an intraoperative MRI scan, probably 10 times as expensive as the Brain Suite CT scan, much more cumbersome to operate, to set up and use, does not see bone pathology like the CT scan does, therefore much more useful in spine surgery. We'll talk about the difference briefly in that we know there's a CT scanner that's coming that's not on rails and it's portable, but we will not dwell on that for now. Next slide. The key word here is this word, automatic, which is what Brain Lab does that the older systems do not do. Whenever we do a case in navigation, we need to do what is called registration for that particular patient. We need to take anatomical landmarks to begin with, be it in the skull or in the spine, and this registers the particular patient to that set. In other words, if you take those landmarks and go from Tom to Dick and Harry, it doesn't work. It's particular for that patient. As surgery proceeds, the anatomy, as I showed you earlier, changes. When you start debulking the tumor, the brain shifts and you're off by millimeters. The software of Brain Lab automatically changes and adjusts for it. There's no need to re-register the patient, which saves time. And certainly, with this system, it's much more accurate, it's user-friendly, faster, and therefore less time spent under a general anesthetic. Next slide. This slide shows how Brain Lab can be used. It can be used, for example, with ENT, where an ENT surgeon is in one sinus and he thinks that endoscopically he's looking at the whole sinus, but he's not, because there's a partition and he's only cleared half the sinus, which means take back to clear the second half of the sinus. Brain Lab will eliminate that aspect because you'll realize that you're only in one half of the sinus. The other things that we can use it for is complete tumor removal, which I alluded to earlier, removal of blood clots in strokes. We know that the whole blood clot is removed, which is really quite critical when you treat people with brain hemorrhages. Our congresswoman who was shot in Arizona probably had a CT scanner in surgery to make sure that bone fragments were not left behind along the trajectory, because bone fragments, once they're introduced into the brain with hair and skin, are potentials for brain abscesses, which the patient will suffer subsequently from. So using the intraoperative Brain Lab and CT scan, you don't miss these fragments. Also in the pedicle, as I said earlier, if you're not exactly within the pedicle, here's an example of a screw going through the pedicle. When you start putting your probe in, you actually look down the barrel of the gun and you can see the bullseye, and you bring your pedicle probe in, sometimes even percutaneously. You could be 8 inches away in big people my size. And you go to the bullseye, and this bullseye will allow you to make sure that your pedicle is properly screwed. In fractures of the long bones, it's sometimes difficult to align the intramedullary nail within the long bone. You think you're in the long bone, but you're really not. So this will help you. This will guide you to get your alignment perfect and get the intramedullary nail inside the fractured long bone. Next slide. I'm getting very close to the end of my talk. I appreciate your patience. I want to show you a picture of a typical operating room and how busy the operating room gets when you do brain surgery. You can have a 500, 600, 750 square foot room, and yet the room is full. This picture shows you, actually this is a picture of our visit to Arizona. This shows you everything that goes into the room when you do a major spine case or a major brain case. Nothing is coming from the walls. Everything comes either from the ceiling or from below. And this is the way our new operating room suites will be planned. Why is that important? because you need to get around the patient while you're working. And it's so easy to leave a wire like this. This is a no-no. And you can trip on that, bring the whole thing crashing down, contaminate the whole case, and you wind up with major problems with infection. So having said that, our new OR will be one of the finest in the country. Actually, we recently went to UCLA and we saw the operating room of the future. These ORs will be better than that because they don't have the brain lab that we are seeking. They are vying for it and they're trying to get it, and hopefully we'll get it before they do. Not that this race matters, but I'm just trying to demonstrate the quality of neurosurgical care we will be affording our patients by establishing this OR in our operating room. Next slide. And in closure, we all know our mission statement, but by adopting policies like we are doing now, my congratulations to the board of directors and administration, we are absolutely satisfying just about every point on our mission statement. Thank you very much.
Thank you, Dr. Taggioff.
Questions?
Are there additional questions?
So in summary, we have two issues. We have the operating room budget of $3.6 million that we're looking to approve, and purchase of 2 brain labs for $2,890,000.
Madam President, I second that motion made by Dr. Nicholson.
Thank you. Being no further discussion, all in favor?
Aye.
Motion passes. Dr. Taggioff, you will have your operating rooms.
Tonight?
Well, not tonight, no. Patience. Thank you.
Item C, Madam President, I move for adoption of resolution number 1103, which is the memorandum of understanding between Nancy Farber, authorized representative of Washington Hospital, and Operating Engineers Union Local 39, effective October 1, 2010, in accordance with resolution number 331A as amended.
Second.
Any further discussion? All in favor?
Aye.
Aye.
Motion passes. Thank you. Next item.
Item D, Madam President, in accordance with district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with implementation of the Morrissey Medical Staff Credentialing Software for a total amount not to exceed $159,114. This equipment was included in the fiscal year 2011 capital budget.
Second.
Do we have discussion?
Yes, the Morrissey credentialing software would replace software that we currently have in the medical staff office that is at the end of life and only automates a portion of the work in the department. Morrissey will specifically allow the pre-application credentialing applications and CME meeting attendance and routine reporting to become streamlined and managed exclusively through the application instead of paper. Physicians will be able to review their files as they're applying and update their credentialing packages online. Morrissey is an Epic recommended provider. And the hardware, labor, implementation, service, and other costs is $159,114, and this is in the fiscal year 2011 capital budget.
Thank you, Ed. All in favor?
Aye.
Motion passes. Thank you. Next item.
Item E, Madam President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the implementation of the Microsoft upgrade project for a total amount not to exceed $1,981,396.
Second.
Ed, do we have a description?
Yes. Washington Hospital is using significantly outdated versions of Microsoft products that are mostly were installed in 2003 and are nearing the end of their support time. The products that are going to be updated is the Active Directory, Microsoft Active Directory, which is the employee system account management. The Exchange system, which is the email system, Microsoft Office, which is word processing, spreadsheets, and presentations, and SharePoint, which is the project management and collaboration database. The cost of this is $1,981,396, and this was included in the capital project budget for fiscal year 2011.
Thank you, Ed. All in favor?
Aye.
Motion passes. Thank you. Next item.
Item F, Madam President. In accordance with district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of hardware, software, and implementation services for the Accelera upgrade and WIT system replacement for a total amount not to exceed $1,201,498. This equipment was included in the fiscal year 2011 capital budget.
Second.
Second. Ed, do we have further description?
Sure. The WIT system is the main system in the cath lab that collects hemodynamic monitoring, associated imaging, and allows documentation. The current system is approximately 14 years old, is at the end of its life, and needs to be replaced. The new system will allow automated inventory control, access to standardized cardiology patient demographics across several applications, reporting, automated and standardized QA reporting, and cardiologists will have the capability of viewing both cath lab and echo images within a single consolidated application. And as noted, it's $1.2 million and within the budget.
Thank you. All in favor?
Aye.
Aye.
Motion passes. Thank you. Catherine, I believe that we have a closed session. Thank you. Meeting is adjourned for a closed session. Thank you. The meeting is reconvened, and I would like to report that no action was taken during the closed session. There being no further business, this board meeting is adjourned.